All right, I'd just like to say welcome. This is day 3 of NSW Mental Health e-Symposium for Schizophrenia Awareness Week. It's a lovely afternoon here in Sydney. We have the sun shining, which is great from wherever you're watching for today and participating. I'd like to introduce myself. My name is Kathy Borman, at least I know what my name is. Kathy Borman, I'm the CEO for NSW Mental Health. I'll get going by acknowledging the traditional custodians on the various lands we're all meeting on, and to pay my respects to their elders past, present and emerging. I'd also like to acknowledge all people with the lived experience of mental illness as we walk together towards a world in which people with mental illness are treated and valued as equal. So welcome. It is wonderful to have you here. And I keep seeing people come. We're just putting in our chat where you're calling from, and it'd be great to see all the different people and the different lands that people are calling from. Today we're focusing on the lived experience, and I have 2 wonderful speakers I'm going to introduce you to very, very soon. Just a little bit of housekeeping. Throughout the talks from our speakers, if you want to ask a question, the only way you'll be able to do it is by putting it in the chat. So if I can encourage you, when you think of it and you want to have that asked, put it in there, and we will collate that and make sure that we hopefully be able to get to it and have a discussion about it. So that's the only way that you can do it, so I just encourage you to do that. I think it's quite apt that we're focusing and talking about lived experience today. I saw some exciting news this morning that Being, which is the consumer peak here in New South Wales, will soon be operating a program called Being Supported, which is a mental health peer support line. And it's going to cover the whole of New South Wales and be run by people with a lived experience to support those of us who need support during this time and during COVID. And so I'm really encouraged that that has been announced and has been funded by the New South Wales Mental Health Commission as well as the New South Wales Government. So that's a great initiative that I heard from this morning. And it's wonderful that that leads into us talking about lived experience and really focusing on that for the next hour. So I want to introduce you to 2 remarkable people. Richard Schweizer, who's a person with a lived experience of schizophrenia, and Bernie Mullin, who's a carer of a young person with schizophrenia. I feel honoured to be here amongst these 2 wonderful people and also to know them. So I'm really encouraged. I'm looking forward to what the next hour is going to be like. So let me just introduce you to these people. Richard works part-time for NSW and also for the New South Wales Mental Health Commission as a policy advisor. He has a degree in arts and law, a master's in journalism and a PhD in the sociology of schizophrenia. Richard's brain is amazing and I love having conversations with him. It's wonderful. And to Bernie Mullin is a recent NSW board member. She's a public health doctor with a background in quality and safety, data and health system transformation. I'm very apt to be talking about as a carer, how the journey of navigating the complex mental health system. So I'm looking forward to hearing from both of them. But before we kind of get into the nuts and bolts, and Bernie's going to kick us off, but I have just a check-in question, something that we do here at NSW, and it's totally unrelated. But so Bernie and Richard, you've got to answer. When you go to the movies, what do you choose? Do you choose to eat popcorn or Maltesers? You can't have both. So Richard, what would you like?
Oh, I'm a popcorn kind of guy.
You can't have both.
You can't have both. You can't have both.
I'm a popcorn kind of guy.
Yeah, I think I'm a popcorn.
You're a popcorn.
And I'm a popcorn kind of girl. Kathy, how's my internet going? I'm getting messages to say it's unstable.
You sounding fine to me, so
okay.
You're all good. Yeah. So we'll cross that bridge, but you're doing really well. For me, I'm a Maltesers girl, so you know, you'd be purchasing Maltesers for me when we get back to the movie theatres. But I'm thinking that maybe the drive-ins might get a bit of a kickback in life, I think, during us responding to COVID. So if I can welcome Bernie. Bernie's going to talk to us for the next little while about her experience of being a carer. So I'm going to hand it over to Bernie.
Great, thanks so much, Kathy, and everybody who's out there in the internet land. So I'm speaking today as a parent of Emily, and Emily lives with schizophrenia. I'm speaking as a carer, representing myself, and also Anthony, who's Emily's dad. I've talked with Emily about what I'm going to say today, and she's very happy for me to talk about the experience we've had together. She knows that she's lucky that she has parents who are doctors and who understand how the health and disability system works in Australia, and who can help her when she needs help. So just a little bit about Emily. Emily's in her 20s. She lives with us as a family. She has a younger brother and sister who are both studying at uni. And Emily's had a severe mental illness now for about 10 years. So we've experienced together many challenges, navigating through our complex, fragmented system, finding some amazingly good people in the system, but finding it really challenging just to get the right care at the right time. So Kathy, I thought I'd use this opportunity to talk about a few things that we've found important. One is we've needed to be a strong advocate for Emily. We've worked really hard to try and create an environment where Emily feels included. And then a little bit about how we look after ourselves as well, because I think that's really important for carers to think about themselves as well. So over the last 10 years, it's definitely been a lot of work for Anthony and I. We try and work together, conquer and divide, work to our strengths. I'm the advocate, he's the peacemaker. And I think, you know, we've worked well together as a team, and we've been lucky to have that as well. So I thought I'd share a few stories about what it's meant to be an advocate for Emily, and often it's in really very practical ways. About 4 years ago, Emily was at another psychiatric hospital, one that she had not been at before, and we were giving them some information and saying we thought it would be a really good idea if Emily could come for a walk with us now around the grounds, because we've found in the past that it works really well, to continue to give her a sense of freedom. I got a really unexpected yes. It's not often that that happens within the first 24 hours. And we met a great psychiatrist, and he told me, and I still remember very clearly to this day, that that was my role, to be an advocate for Emily and to tell people what she needed. Because, you know, as parents who've lived with her through this journey, we know her a lot better than a new care team. So he told me I should never stop apologising for being an advocate too, because I think I probably apologised and said, look, I'm sorry, but, you know, this is what we think. So that was very empowering. So I often do that now. I find myself empowered to talk to people about what we know works well for Emily and what she finds help her. And I often talk with nursing staff about the importance of patient-centred care, because I think it's a real-life practical example of how the system needs to start to think about that in a real way. My favourite is policies. So you can't do that because it's against our policy. And often if you go high enough up the hierarchy, you find that there is a way to do things that are patient-centred. It's just that it needs to be documented and thought about in a careful way. So we know, for example, that when Emily's in hospital, it's really important for her to stay socially connected with us, and using, you know, when you're in your 20s, Facebook Messenger and other mechanisms are the most appropriate ways. So, you know, we continue to try and create opportunities for Emily within the care system for patient-centred care to happen. We did find in her recent hospital admission that a phone group doesn't mean you can use your phone. Just means you can hold your phone. So we carry on, you know, trying to create a system, I think, that works better. We know that Emily can't always speak for herself, but I think that Emily knows that when things get tough, Anthony and I both have her back. We're there to support her through navigating the NDIS and the health system. Probably one of the really important things I think we've done is we've spent a lot of time navigating to the right care team. So Emily has an amazing psychiatrist, a great GP, and a multidisciplinary team of carers who actually all know each other, and we facilitate communication between them all. Because I think a health system that is integrated is just essential for people living with severe schizophrenia. Another thing that we've learned is the importance of Anthony calls it organizational person power hours. It takes a lot of effort, a lot of time, a lot of perseverance at times. Emily has important medical records scattered across 5 hospitals who don't talk to each other. So we spend a lot of time facilitating the communication of information between different specialists from different systems. I've just recently, or I'm in the process of working up a review of a reviewable decision for Emily's latest NDIS plan, and I estimate it's taken me about 40 or 50 hours to get all the paperwork together. So making things easy, helping Emily by helping her to navigate the system, I think is a really important part of what we've been able to do with Emily. I also think it's made a real difference. At the beginning of Emily's NDIS journey, we were told that we wouldn't be able to self-manage Emily's NDIS plan because she was too complex, that it was against the NDIS's policy to self-manage for complex patients. So that took a lot of phone calls, reading the legislation, a lot more phone calls, and we did get there. So I don't think that anyone can underestimate the work and the effort that's required, not just by people in the system, but also from carers. But I think it's been critical for us to be able to self-manage with Emily and her team. She now has an amazing team of support workers, some of whom have been with her now for more than 18 months, which is amazing. At the beginning, there was a lot of turnover, but now she's got a great team of young women. They're all got complementary different skills. Some are from the NGO sector, some we've managed to recruit privately. They're amazing at building up Emily's self-esteem and confidence. They're much better than me at taking her shopping. And they've allowed Anthony and I to leave the house, where previously there was always someone in the house with Emily. I think part of the advocacy has always been about out-of-the-box thinking. We've always had to think about what is the best thing for Emily and how can we turn this around to work for her. So some really simple things took quite a lot of work. Getting organisations to communicate with Emily on WhatsApp, because that was the system that Emily could work with. She could see the train of conversations. I could be in the conversation to steer if things looked like, we were organising things at the wrong time. So, simple things like that have been really important. We've managed to get her support team to go into hospitals and to stay in touch with her when she's in hospital. Because again, I think that's been critical to creating an integrated care system for Emily. It gives her hope to know that when she's back in the community, the people she knows are going to be there and available for her as well. So I don't think any of us can underestimate, I guess, the work that carers do, but also how important it is to get the right care for people. The second thing I wanted to talk to everyone about was we realised that one of the most important things for Emily is how people make her feel. And she knows how people make her feel. When she's treated with respect, when the system treats her with respect, when people treat her with respect, and understand her feelings, understand that sometimes things need to be explained differently, she feels included. We've got some amazing staff at our local cafe who are, have a very friendly approach to Emily. There are some nursing staff at our local hospital who say, when Emily comes back into hospital, it's nice to see you, acknowledging that, it's not good that she's there, but she feels that it truly is nice for them to see her. And I think support workers who have lived experience have been valuable for Emily as well. They give her hope. and they've certainly been able to relate to Emily in a way that I think has been more difficult for others. So I think we all know when people are treating each other with respect, and for people with a complex mental health illness, this can be difficult. When people ignore her or treat her differently because she's disabled, that's a real challenge, both for her and for us. And then the third thing I was going to talk to everyone about was, I don't think we always do it well, but Anthony and I do try and look after ourselves as well through the process. Even though we have a great team, we still do most of the caring. We're responsible for keeping Emily safe and helping her to do the things that she wants and needs to do. And we get stressed. Emily recently spent 12 hours in a resus room because there was nowhere else for her to go, and that stresses us out, unsurprisingly. So we try to create time for ourselves. I go for long walks. Before COVID, it was with my friends and talking, and now it's with our dog, and we still talk. So I'm very lucky. I've got a very flexible employer who lets me work from home, and I'm allowed to leave at short notice if I need to. And I also think I've got a job that gives me a lot of ability to think about how the health system works, which I find very fulfilling as well. So Kathy, that's it from me. I really just wanted to finish though by saying that we're optimistic for Emily's future. We can see that she's becoming more independent. We're hoping this next review of a reviewable decision will result in some more services for Emily to support her living independently. But I'm keen to hear others' experience as well, because I think one of the really important things here is learning from each other.
Yeah, no, totally agree. Thank you. That was wonderful to hear. And I've got a lot of comments and questions and stuff. But, I'll wait and I'll hold them. I've been writing them down. So that's great. So if I can introduce Richard, and Richard I've known for nearly a year and a half now, I think, Richard. It's been wonderful. And Richard has been a great person to thrash ideas around, and he's got a very large brain, and we have amazing chats about various things, and it's great to be able to talk. But I'm going to stop talking, Richard, so you can talk and share your journey and your story.
Okay. I'd like to thank One Door for inviting me to be here today. And I'd also like to thank all of you watching online at home or at work. And for many of you too, those two places are the same. I was diagnosed with schizophrenia 16 years ago. Luckily, I responded very well to the medication called clopine. And so I'm able to live a pretty normal life. I go to work, have friends, socialize, and do the things that make me happy. The theme of the One Door Symposium this year has been staying connected, and this is certainly relevant in light of the COVID shutdown, but it's also a theme that's of particular interest to me. It interests me at an academic level. I wrote my PhD about the sociology of schizophrenia. That means I wrote about the social side of schizophrenia, how people diagnosed with schizophrenia were affected by their social worlds. Now, this isn't something that is always approached from that perspective. A lot of people approach schizophrenia from a neurobiological or neurochemical perspective. I was interested in the social. At a policy level, in my work at One Door and with the New South Wales Mental Health Commission, there's an interest in changing the political and social world so people with mental illness can live fulfilling and stigma-free lives. And of course, at a personal level, as a person who has been diagnosed with schizophrenia and has suffered both anxiety and depression, I think my social circumstances have been a big factor in keeping me here and allowing me to achieve the things that I have. So at all these levels, it seems clear to me that a person's social connections can help them cope and hopefully recover from mental illness. I've listed in my notes here 3 ways that social connection can help. One is quite mundane. Mum and dad driving you to the chemist to buy medications, reminding you to take your meds, helping you to manage side effects such as drowsiness or weight gain. And for me, that mundane support has been unconditional and mainly financial. My parents support me living at home and supplement my income, for which I'm eternally grateful. At an emotional level, having a strong social network and family can really help you keep your boat afloat, so to speak. Being able to talk to people who care, having a shoulder to cry on, having people to take your attention away from your demons, all these are vital aids to recovery from the mental ill health. And I can speak to this from experience. I have developed around myself a network of social supports. This includes my GP, my psychiatrist, my psychologist, and of course my family. Special mention must also be made of my brother Marcus, who can't be with us here today, but I'm sure will watch the recording. He's always been there when emotional turmoil has become too much for me. Finally, there is a deeper level at which social connections can help recovery. Even recovery from serious illnesses such as schizophrenia or bipolar disorder. This level is the level of love and the level of hope. Love keeps you strong. It builds your self-worth. It provides what Paul Keating described as an asbestos suit against the fires that life can hurl at you. And hope motivates you to keep going, to keep trying new medications, to keep engaging in new treatments, and to wake up every day and hope that it's going to be better than the day before. So at the deepest level, love and hope both come from social connections and develop because of your social connections. So I think I'll leave it there so we have some time for discussion.
Thank you, Richard. You made me smile with your quote for Keating. Richard gave me a book, which I haven't even touched yet, which is this kind of very thick, is it autobiography or biography of Keating?
It's a biography by Don Watson.
That's right. So yeah, I've got a bit of reading to do on that one, but it's fascinating. So thank you so much to you both. I think one of the consistent things you both talked about was hope, and both of you have that in spades, I think, in lots of ways. And Richard, you've spoken about your social connections and the importance of your family, and Bernie, similar. I'm just wondering where a lot of people with a lived experience, both carers and those living with the illness themselves, struggle with that. How is it that there might be some ways forward or some ways that we can support others around this to kind of gather on that hope of what both of you spoke of quite powerfully?
Richard, do you want to go? I'll go first, sure. Yeah. I think at one level, medications and psychopharmaceuticals can provide hope. The hope that they're going to develop better medications that are more, I don't want to use the word accurate, but more focused on the specific symptoms people have for mental illness. And I think a recovery-oriented practice, having people you work with who know that, who can draw out of you your goals and hopes and also your strengths, and join those two things together so that you can try and work towards your goals, be that employment, having relationships, education, training, whatever, exercise, whatever it may be. I think a recovery-oriented approach is important in creating hope in that way.
Yeah, absolutely. Bernie?
So I think, I don't want to appear overly optimistic. I think there are some days where, Emily and Anthony and I feel not a lack of hope, but you know, some days are better than others. I think. I think what has made some days really good is where Emily's supported and we feel supported. I think that's really made a difference, to feel that you're not on this alone. That there is a system that is nourishing and around you and provides that. Emily's dad is a researcher and is working a little bit in mental health research now too. So like Richard, I think, you know, it's a very evolving arena. There's a lot of new treatments that, you know, even 2 years ago, I think, weren't being trialled in schizophrenia. So I think there's always the hope of, you know, new treatments. I think peer support workers have been amazing in terms of creating hope. And probably also people who see Emily's strengths and work with those. You know, not always seeing the things you can't do, but the things that you can do on a day-by-day basis. So just, a few thoughts about things that have been important to us, I guess.
Yeah. Bernie, you spoke about I think you had patient-centered care, but let's flip it to
person-centered care. Yeah.
That's what you mean. I know it's a challenge when it's not only from a CMO organisation such as One Door, but obviously there's public health, mental health teams, mental health inpatient units. And I think this label of person-centred care gets bandaged around it quite a lot. But I'm just wondering, from both of your perspectives, what would you see as being the kind of crux for providers around being able to deliver on person-centred care? If we were to kind of break it down, what would be the most kind of key things for you guys around that? Bernie, you want to take that one?
Yeah, I'm happy to. Look, I have been involved in some so-called co-design projects, working with consumers in cancer, understanding the world from their perspective and redesigning services. And so I think the key thing is listening. Listening with an open mind to what might be possible. Because I think we all know that the hospital health system developed out of Florence Nightingale and the army and the military. And I think we still struggle in our mental health system to flip that around into something that works around patients. Handovers are too frequent. You know, Emily at one point was in 6 hospitals in 1 admission. I mean, that's just crazy. So I think for me, the key thing is thinking about what's possible and flipping it to think about it from the patient's perspective, not how the system works.
Yeah, absolutely. Yeah.
Or the person's perspective. So for me, it's mostly about when she's in hospital, which is why I say patient-centered, but I think there is definitely a community element too.
Absolutely. Richard, from your perspective?
I would repeat what Bernie has said, and perhaps just offer the idea that the mental health workers can offer information and they can offer choice, and that can be choice about your treatment in particular. And I think there's a thing called the dignity of risk, which is allowing people to make a choice where that may not be what their psychiatrist or their mental health worker thinks is in their best interest, but there's a certain dignity in allowing them to make their own choice about that treatment.
Yeah, beautifully put. Thank you. That's wonderful. Yeah. Yeah, some questions from the lovely people who are joining us. It's sometimes we forget because we can't see them, but I'm sure they're wonderful looking people. But question first for you, Bernie, is what are you thinking about future living independently? So at a time, wherever that might be in your life, sometimes, it's the person who's asked this question is about when you're too frail to care for her, or what's the journey that you and Anthony are on in that space?
Yeah, absolutely. And look, I think we've been thinking about this for a long time. And we've actually moved house. We moved to an area where we think the services were better for Emily, because we were living in a more suburban area where I think it was hard for Emily to relate to the community. So we've moved house, and about 3 weeks ago, we moved out of that house because it's been demolished and it's been re-renovated into something that will be able to have Emily in semi-independent living. So it'll be a separate apartment and we'll be in another apartment. So we're starting to plan that now. Because hopefully we've got a few more years left with Emily, but we want to establish, I think she's in her 20s, she needs to have some independence if possible, and we're looking for the NDIS to support that as we move forward.
Yeah, okay, thank you. Question for you, Richard. What is the single most helpful thing that has been done for you in your recovery journey? You got to pick one, but I reckon you can.
I can pick a few. Look, I'll tell you the truth. When I was in the clinic for the first time, a nurse called Nessie sat down and talked to me. And she said, "Oh, Richard, you're a really intelligent person. You've done all these degrees." And just chatted with me about how I felt. And that was a chat that was not, well, it was therapeutic, but it was not aimed at trying to achieve some particular goal, but rather to recognize me as a human being. And that was something that I really valued at the time. So being able to be seen to be something more than your diagnosis. The other one I would pick, having suffered anxiety or depression, having close friends and my brother whom I could talk to when things were getting tough. I think that's really important, to having an outlet and someone who can support you and guide your thinking when your thinking is gone a bit awry.
Yeah. Thank you, Richard. This one is a big question, and I think we could probably have a debate on this one for a long time, but it's very much actually a question that I had, but maybe a bit different. But in terms of what could mental health organisations do better? Now, there's potentially a realm of things we'll think of. So maybe just your top three, but I guess around what are some of the standout things that we could all, as organisations, including public and in the community managed sector, to the GP, what are some of the ways that could be done better to improve the experience of people with lived experience and carers?
I mean, the one thing that we're really struggling with at the moment is integration and multidisciplinary, because we think, and Emily thinks, she needs a team. Well, we work with a team of people. It's so hard for us to work together with them because the public hospital, the private hospital, the providers from different organisations, all whom have their own records. So we create shared opportunities. We had a multidisciplinary Zoom meeting. A fabulous psychiatrist is happy to be involved, but I think that's rare. But I think for many people with a severe mental illness, having that kind of one system, not fragmented systems. So Kathy, if One Door was working closely with the LHDs and the hospitals and the community mental health services with one set of shared notes and one data set, Richard, where we were all monitoring how people were going and then targeting services to where the highest need was. That would be my kind of my vision, I guess, because if the system doesn't support it, it's really hard.
Yeah, absolutely, totally agree with that one. Yeah. Richard?
I would also use that word integration. I think there is a lot of fragmentation in the mental health system, and it can be difficult for someone, particularly at the beginning of a mental health journey, finding out where the services are and who gives them and what is suitable. I might make mention here, during a research project that I did recently, the Nepean Blue Mountains Public Health Network, PHN, have a really fantastic web-based system where you can put in what type of help you're looking for, and it will come up with a list of all the people in the Nepean Blue Mountains area who offer that kind of hope. So that website, or that web app, I suppose you would call it, really aids the integration of mental health services. And it makes things easier for people who are starting on their mental health journey to learn where they might go to their best benefit. The other thing I would say is to again emphasize having a recovery-oriented approach, and also, of course, having trauma-informed care and care that is culturally sensitive to ethnic groups, refugee groups, and Aboriginal groups.
Yeah. Bernie, you spoke, I mean, the fact that you and Anthony are both doctors, obviously very strong advocates. There are a lot of people in positions who, carers who might feel not strong enough to push, and you guys have obviously advocated in an amazing way for Emily. When I look at there are a lot of people who aren't in that type of position to then push or feel that they have the words or the knowledge, I mean, both being doctors and those kind of things. So what would be, I guess, some of the advice, not only to carers who might not be in the position you're in, but also to those of us on the other side that are trying to support people? What are some of the ways that we can do it? And I agree with you about the fact that, simple things about communication, it's not hard. I think systems make it really hard. So how can, what are just some simple ways that you could help people in their advocacy for their loved one, or those kind of things that would help around that?
Look, I think perseverance has been critical. Finding the key people in the system. You know, there'll always be one nurse who is experienced and who understands, who gets it, who can become your advocate or a social worker or someone in the system. So find that person, keep going till you find that person. You know, if you've got an NDIS plan, it might be your support coordinator. It has really transformed our thinking, actually, to have suddenly got ourselves a very experienced support coordinator. And that's been very empowering, even for us, you know. So I thought I knew a lot, but she knows a heap. So yeah, find the person. If it's not you, and like Anthony and I know that we, you know, Anthony and I do different things, and he doesn't so strongly advocate in the moment. So if you can't do that, find the people who can help you.
Yeah. Okay, so a question for Bernie, another one in terms of what are your thoughts on the importance of all the care support team knowing Emily in her wellness and unwellness? It's a good question.
We share videos of Emily before she became unwell with her carers. We found that really powerful. I mean, we find it powerful to look back and think, you know, she was so well, so happy. And she loves, I think she loves that as well. So that's one way we've done it. I think it's a shame the NDIS don't get to see the unwell bits, to be honest, as well. That's one of the things I'm just trying to think about now. But look, I think that's been the key thing for us, is people often see her when they're unwell and they lose the person there. She becomes the number. Yeah, but at other times, look, I think there are some amazing people who really know Emily and know her personality. So that's also made us feel happy.
Yeah. A question for both of you. How can services, so I'll just put that in the broad of both public and not public, how can services do better at getting the lived experience voice more prominent and powerful? Like, what can services do in that space? I know that there's a lot of talk around it. We saw the National Mental Health Commission launch its National Wellbeing Mental Health Pandemic Plan on Friday. There's a lot of talk in that around lived experience being important. I'm just wondering, from a practical level and as interfacing at different parts with different providers, how can we make sure that that's up front and centre and heard? Richard?
Look, I think the answer to that is culture and politics. So by culture, I mean organisations need to accept that people with lived experience of mental illness can often offer an insight into their clients that perhaps people without that experience can offer. And a cultural change to accept that people with mental illness may, they may need to take a few sick days now and then because they're feeling anxious or depressed, but they're still valuable people to have on board. So that's the cultural question. The political question is, are our politicians really behind the lived experience workforce, behind lived experience reform? And I think we have a duty as people who work in the mental health sphere to bring that politics to the politicians.
And what's the answer to your own question on that one, Richard?
My own question?
Yeah, well, your own proposal about the politicians.
Okay.
So I guess you put it out there. Let's
Well, people with lived experience need to be working as advisors for mental health ministers.
Yeah.
And people, like yourselves, Kathy, who have access to politicians, need to explain that this is an important issue.
Yeah.
I'm not trying to put something on your plate, but I'm trying to answer your question.
Yeah. No, I just wondered what that meant in practice. So when you're talking about it, but yeah, that's true. For Bernie, as being a carer, what do you think is important about that? Your reflections and experience of walking this journey. How do service providers get better at this, of making sure your voice is heard and acted upon, not just listened? I think listening is important, but I think around how do we actually change because of what we're hearing?
That's right. I mean, I was thinking about a few things. One is, in the commercial world, it's really important to listen to customers, understand the customer experience, and act on it, or otherwise you go out of business. I think it would be nice to think about what the imperatives are and how you could flip that in the health system, so that, without those things, it doesn't work. I think we do very high level customer, experience surveys. And then we think we've ticked that box. Yes, we've incorporated customer experience and we're measuring it. But I think there's a huge gap at a very practical level.
Yeah.
I don't think, I think the reality is that most people have not walked in the shoes of people with a severe mental illness in Australia. And I'd like to design an experience, I think, for that, so that, people really knew what it was like, how hard it was. To do that, because you can intellectualize it, but I think until you've done it, it's very difficult.
Yeah. I'd be interested to see how we could do that collectively, as not just from one door, but across the sector, how we do that. Brilliant, good idea. All right. So a question for you, Bernie, is what type of NDI support have you been able to source for Emily apart from shopping and companionship? I'm sure there's more in it, but yeah.
So look, we've got a little bit of capacity building support for Emily, but that's what we're primarily going back to the NDIS for now, because there's nowhere near enough to support Emily to be where we think she can be with the right support. We also don't have enough support worker hours to cover the time that she needs someone just to be with her to keep her safe. So I'm not sure why we didn't get it. So we're persevering, and we'll go all the way through until we get what we need to allow Emily to be in the community and be safe at home. So we've got, so we've obviously got transport, we've got support coordination, and we've got some limited capacity building support. So, so we're going back to get more. I think there's no doubt that self-managing Emily's plan has been key to be able to do the things that we do. There are not that many services that are suitable for young females. So, you know, it's not about going to community centres, you know, for Emily. It's about how we can create experiences in the community where she's supported and she feels that she's doing what other young women in their 20s do. So, yeah, so I think we have the regular. It's about, have we got enough of it?
Yeah.
At the moment.
Yeah. Question for both of you. What do you think about a TripAdvisor type site of consumer reviews, particularly for psychiatrists? For those of us still floundering to find one who is interested in their profession and the person. Yeah, so that idea of TripAdvisor, I know that there was and I can't remember it off the top of my head, but there is a website where people can comment on certain providers, as in organisations for NDIS. I can't remember what it's called, but it's similar, that kind of idea. But yeah, what are your thoughts on that one? It is a bit about that kind of Google rating, TripAdvisor. It's interesting though, I agree, when you're sourcing a certain website, well, I know for me, I'll look at the rating and that kind of stuff, but sometimes when it comes to professions, we don't have that kind of transparency of what other people have thought or experienced. And it goes a bit to what you're talking about, Bernie, around that customer experience survey. I mean, the traditional one in mental health services is your experience of service survey. But it's that kind of, how do we become more that? That's a good question about that. What's your thoughts, Richard, on that one?
Thanks for the question, Kathy.
It wasn't mine. It was a lovely person.
Okay.
Yeah.
To quote The Simpsons, what a good-looking question. I think it's a great idea. I think that a number of psychiatrists would not be happy about it, but it links me to a conversation I had with my psychiatrist recently, and I asked him, you know, do you think that psychiatrists should be required to bulk bill a certain amount, because it's very difficult for people with mental health concerns to find a psychiatrist who is both good and bulk bills. And he, to my surprise, said yes, he thought it was a good idea. So maybe he would also say yes to a TripAdvisor style rating for psychiatrists.
Bernie?
Look, I think there are some, Kathy, because I have done some mystery shopping in the past.
Okay.
So
Yeah.
I think they need to be well moderated, would be my main comment. I think some of the work the government are doing at the moment with making out-of-pocket costs visible in the government website. I haven't looked at that for a while, but I think that's hugely valuable. Just to Richard's point about, and to Richard's point, I agree completely that I think there should be a proportion of psychiatrists, a proportion of patients for whom psychiatrists bulk bill, or a star rating system for those who do. So, yeah, I do think it is really important to be able to get information, and also important, if it doesn't work, to move on. I don't think we've had that experience, and we've had fantastic psychiatrists who work in partnership with Emily and with us. But I think helping people navigate to those is actually really important.
Yeah. I think that's a common thing you both talked about, was getting the right support team, and for both of you it was finding it. Bernie, you really pushed and pushed to make sure that support team is what you needed, and it sounds like you're finding it from all your hard work. It's sad that that's put on the onus of yourselves around finding that, and that there isn't something that's that we're not. There's a lot of way we've got to go in being able to provide what is needed. So, yeah. In terms of there's a question here for both of you. For someone looking to be more supportive, what would be your number one pointer to help others with being more understanding?
Bernie,
you want to go first?
Yeah, I think, you know, people who I see it in people's reaction often immediately. I think the really important thing is people with severe mental illness, just like you and I, just like all the regular people in the street. So the one thing is treat people like they're regular people and respect them. You know, whether it's the homeless man who lives in our park around the corner, you know, I see amazing acts of kindness to him. I'm sure, I don't know, but I'm sure he has a severe mental illness. So I think just treating people like they're regular people and with respect.
I would fully echo Bernie's comments. Having respect and understanding as well that this is the way we understand what mental illnesses are, and explain that there's still a person down there in the center of that being. They're not just the diagnosis. And I guess acts of kindness. I mean, I'm touched by the story of the fellow in the park that you talked about, and the acts of kindness towards him.
Yeah. I think and the word you used, both of you used, respect, and I think that is clear, and it's a good place to start, of that respect each human being, wherever we whoever we come across, and I think you're able to move a lot of things with just starting from that basic premise, and it's a beautiful way of putting it. Bernie, a question for you is what advice would you give to CALD, so culturally and linguistically diverse parents who were not allowed to see their son in hospital? Now, I'm not sure of the details, but is there kind of avenues within the hospital system you know about?
Yeah, there are advocacy services available. So my internet's going out a bit, Kathy, but there are definitely advocacy services available. I've used them in the past, both patient advocates within the hospital and also legal services outside of the hospital. I'd say don't be scared to pick up the phone. Sometimes just picking up the phone is all you need to do.
And I think it is challenging at this time during COVID, because I know hospitals are, I guess, being a bit more careful about who's coming into the hospitals. So I think that's another thing at this challenging time. But yeah, the patient advocates are a good place to go to and keep pushing around that. So I'm aware of the time, so I'm just going to be able to just do a couple more questions, maybe one or two. Just in terms of, there's a lot of discussion around how the mental health system could get better. We know that the Productivity Commissioner is due to release a big report soon to the government. We know a lot of things like that. Sometimes what can happen is that it gets very politicised, which is really unfortunate. I think at the point of being able to just deliver what is just needed, basic kind of sense services, is sometimes lost in big things that occur. So for the last comments that both of you had, if there's one thing you'd like to say to the audience about what would be one thing as someone living with schizophrenia, Richard, and for someone caring, what is the one thing you'd like as a message for all of us around making things better for yourselves and for those that you love? Richard?
Combat fear. Don't be afraid. Don't be afraid of me. Don't be afraid of other people with schizophrenia. Practice wisdom and compassion, as the Buddhists would say. So wisdom about the fact that sometimes illnesses happen, and you can't blame someone for it. You can't. It's like a broken leg. You can't blame someone for having a broken leg. And if someone is depressed or more seriously has a psychotic illness, you can't blame them for that. And know that they need love just like everyone else needs love.
Wow, very strong.
Very strong.
I'm not sure if I can top that, Richard. I think you've said it really eloquently. I think you've captured all the things that I want for Emily, really. I want her to feel like she belongs, that she has a place, and that she's loved and respected. So, and that comes down, I think, at some level to everybody's individual action, and how we model that as well. So, and I think how organisations like One Door advocate as well for thinking about people living with schizophrenia when government put up policies, when we're having discussions about investment in health services. So I think, I think One Door has taken on that challenge, and I look forward to seeing what it can do with that.
Thanks, Benny. I'd like to thank you both. It's been a wonderful time, and I knew this would be a special day, so I really thank you a lot for your time and sharing more of yourself. It's been a real privilege for me, and I'm sure for all of us here. If we could all clap, there'd be a standing ovation. I'd just like to say thank you to that. To those of you that have joined, I'd like to thank you also. This is not the end of Schizophrenia Awareness Week e-Symposium. We've got a few more to come. For tomorrow morning, one of our partner organisations in Western Australia, Mental Illness Fellowship of Western Australia, has a webinar around their recovery model. So I'd just encourage you to have a look at that. Joining me tomorrow at 10 o'clock is Professor Pat McGorry, and he's going to be speaking to us about early intervention for young people. And in the afternoon, I have also another great chance to sit on the couch and talk with Dr. Stephen King from the Productivity Commission and Catherine Lowry, Richard's boss, around talking about her reflections also for New South Wales. So it's going to be a wonderful day tomorrow. Busy for me, but exciting. And on Friday, we've got a few more. We've got a study, Caring Fairly, which is looking at the needs of carers during this time. And that's coming Friday morning, and Friday afternoon, Esther from Mostly Mad Music. So there's a lot to come. I'd encourage you, if you haven't joined and you have the time, get on board and do that. And so it's been a wonderful time. Thanks again to Bernie and Richard, and thanks everyone for giving your time aside this afternoon. If there's any questions we've not got and you'd like us to follow on, then just email us and we'll get them through. So, oh, hello.
It's Emily. She's just come to say hello. She's been downstairs listening.
Hello, Emily. Lovely to see you. So yeah, we'll say goodbye from there, and thanks for everybody, and enjoy your afternoon.